Biomarkers have emerged as important tools for the diagnosis, for risk stratification, and therapeutic decision making in cardiovascular diseases. NT-proBNP has proven its diagnostic usefulness in large number of studies and does have a progressed from bench to the clinical implications. And clinical applications are heart failure, acute coronary syndrome, acute pulmonary embolism, and cardioembolic stroke. Now, coming to the NT-proBNP in heart failure, it is mainly for the diagnosis to establish or refute diagnosis, risk stratification, and monitoring and therapeutic guidance also it is important. Coming first to the diagnosis of acute heart failure, it is based on the cutoff levels of the NT-proBNP. If less than 300 nanogram per liter, heart failure is unlikely, and heart failure is likely when the levels are more than 450, age less than 50 years, more than 900 when less than between the age group of 50 to 75 years, and more than 1800 in the age group of more than 75 years. Heart failure is likely, and it is to be confirmed by imaging, that is echocardiography. And there are clinical trials which clearly show the importance of diagnostic importance of NT-proBNP in heart failure, the PRIDE study and the ICON study. And based on the results of these trials, ACC and ACC has put the NT-proBNP as a class 1 recommendation for the diagnosis of heart failure. Now, coming to next prognosis in heart failure, it clearly showed that with the treatment on and the levels going down from the baseline NT-proBNP, the prognosis is better. But when the levels goes up based on as compared to the baseline levels, and it remained high as what is there at the baseline, the prognosis is worst. NT-proBNP is the strongest independent predictor of mortality in hospital patients with ADHF. 77% increase in the risk of death and hospitalization at 30 days, and 4-fold increase in the risk of death at 180 days. After ADHF treatment, if the NT-proBNP reduction is less than 30, the reduction is less than 30%, then the prognosis is not good. But as compared to the reduction more than 30% with the treatment, the prognosis is much better. Pre-discharge NT-proBNP help predict the patient's risk for re-hospitalization and the mortality. And here is the importance of serial NT-proBNP measurements for the prognostification in CHF patients. If the level is high, baseline remain high, the prognosis is bad. It remain high, and with the treatment on, if the levels goes down further, the prognosis is good. NT-proBNP for the guiding the heart failure therapy, heart failure management guided by the NT-proBNP would be superior to standard heart failure therapy alone. And NT-proBNP guided treatment of heart failure reduces all-cause mortality in patients aged less than 75 years and overall reduces the heart failure and cardiovascular hospitalization. And these are the biomarker guided heart failure trials. Some trials are neutral but with a positive trend, and some trials have a positive trials. Natriuretic peptide guided therapy in chronic heart failure patients. This is a meta-analysis of 12 randomized trials which clearly showed that NT-proBNP guided therapy significantly reduced all-cause mortality and heart failure related hospitalization, but not all-cause hospitalization, whereas the BNP guided therapy did not significantly reduce both mortality and morbidity. And this is the simple algorithm. And the NT-proBNP treatment, on treatment, if more than 125 picogram per ml, you need to have intensification of the therapy. And if the levels more than 30% increase from the clinical baseline value, then again you have to, more frequent follow-up is needed and intensification of heart failure therapy is needed. But when the more than 30% reduction from the admission value, then patient can be safely discharged from the hospital. Coming to next issue, that is NT-proBNP in acute coronary syndrome. Increased NT-proBNP level is the strongest predictor of mortality in ASCS patients. NT-proBNP is for the diagnostic risk stratification of the patient with acute coronary syndrome with increased death and myocardial infarction. NT-proBNP has a higher sensitivity and specificity for the non-ST elevation MI than ST elevation MI. While the ST elevation MI ACS patient, when there is a myocardial necrosis, then increased level of troponin and CPK-MB are the higher sensitive markers compared to anti-pro-BNP. Increased levels of anti-pro-BNP in non-ST elevation SCSM patients is highly predictive of adverse events, what is seen in the sub-studies of FAST, GUSTO-4 and the PRIS-2 trials. And it also have a short and the long-term prognosis based on the levels of the baseline levels of anti-pro-BNP. What is the mechanism in ST elevation MI? The underlying pathophysiological mechanism was not fully understood, but a direct release of the BNP from the ischemic cardiomyocytes in the addition to the ischemia induced by the increase in the ventricular wall stress is a probable mechanism. And this is also seen in the stable coronary artery disease patients. It provides more prognostic information in these patients with high levels of anti-pro-BNP. Now coming to the next issue, anti-pro-BNP in acute pulmonary embolism. BNP has a limited diagnostic importance in the patient who is suspected of having pulmonary embolism, but has a high prognostic marker in acute pulmonary embolism, which primarily stresses the right ventricle. Persistent elevation of anti-pro-BNP indicates a right ventricular dysfunction and have a poor prognosis. And the meta-analysis of the trials, which clearly showed a higher in-hospital death with higher levels of anti-pro-BNP in pulmonary embolism and high in-hospital mass also. Persistent elevation of anti-pro-BNP levels within 24 hours of the diagnosis indicates ongoing right ventricular dysfunction with a poor prognosis. Next issue, the cardioembolic stroke, the role of anti-pro-BNP, and the study clearly showed that high levels of anti-pro-BNP is for the diagnosis of the cardioembolic stroke and a novel predictor of the stroke risk after the transient ischemic attack. And meta-analysis clearly showed the importance of the anti-pro-BNP as a prognostic value in these trials. So take-home message, anti-pro-BNP in patients with acute dyspnea can guide the diagnostic investigation and the management, reliably discriminate the systolic from the diastolic heart failure, are predictors of morbidity and mortality in acute heart failure. Decreased levels of more than 30% in the response to heart failure treatment indicates a good prognosis. Anti-pro-BNP are prognostic markers in the acute pulmonary embolism, have a high sensitivity and specificity than other traditional cardiac biomarkers in early diagnosis of a non-ST elevation MI ACS patients. They are predictors of mortality in acute coronary syndrome and are the risk markers in ICU patients, but the therapeutic implications remains to be determined. Thank you very much.